Madam, we are live now.
Okay. Yeah. Should I share my screen?
No, madam, just 1 minute. It's 5:59. Just 1 minute. We will start. Good evening, doctors and all the participants. On behalf of Shield Healthcare, I welcome you all in today's medical session on preterm labor. And today's guest speaker is Dr. Alaka Rath, madam. It's my honor to introduce Madam. Madam did her MBBS, PGTMCH, and Madam is associated with Ladies Clinic and Nursing Home in Cuttack. And Madam has more than 10 years of experience in the field of obstetrics and gynecology. So with the short introduction, I request Madam to take over the session, and meanwhile I request all the participants for your active participation, and please post your queries on the QA chat box of the Shield Connect page. So once the talk will be over, we shall have a short discussion on this topic with the Madam. So thank you very much, Madam, for your valuable time to discuss and this interesting topic, that is preterm labor. And over to you, ma'am, for further proceedings. Thank you very much, and over to you, ma'am.
Thank you so much, Mr. Suman, for the introduction. And thank you, Shield Connect, for giving this opportunity to speak on preterm labor. So let's start. Is it visible?
Yes, ma'am, it is visible.
Okay. So preterm labor, despite considerable advances in obstetric care, preterm labor still remains one of the most challenging and unsolved problems in day-to-day practice, and continues to be a major cause in perinatal mortality and morbidity in our country, not just in our country, in the entire world. The definition is, by WHO, onset of labor prior to the completion of 37 completed weeks of gestation, counting from the first day of the last menstrual period. So we come to different phases of preterm labor. Early preterm labor is onset of labor between 20 to 36 weeks. Moderate preterm labor is between 32 to 34 weeks. Late preterm labor is between 34 and 36 weeks. And extreme preterm labor is onset of labor less than 28 weeks of gestation. Approximately 10% of deliveries in public hospitals occur before the 37th week. A very smaller percentage is involved in the 24 to 32 period week. Prevalence varies and ranges between 5 to 10%. The estimated global prevalence is about 9.6%. In India, out of 27 million babies born every year, there are about 3.5 million babies born that are premature. Approximately 5% is the incidence in European countries, but in African countries, it's as high as 18%. So in the risk factors, there are 4 things. History, which is the most commonest and which is the most important factor. Then complications in present pregnancies, iatrogenic and idiopathic. So the maternal factors, low socioeconomic status, age if the lady is less than 18 or more than 40 years, if she has chronic disease like hypertension or diabetes mellitus or anemia, or if she smokes, or if substance abuse, grand multipara, and short interpregnancy interval. Past history, which is the most common and which is the most important part of preterm labor, is if she has had a previous history of preterm labor, if she has had a previous history of second induced or second trimester abortion, or history of any kind of cervical surgery or cervical trauma during spontaneous labor and operative vaginal delivery. Current pregnancy complications, you have preeclampsia, bleeding PV in early pregnancy, APH, polyhydramnios, multifetal gestation, IUFD, congenital malformations, placental infarction is another cause, placenta previa or abruptio. Many uterine anomalies also contribute to PTL. If there is cervical incompetence and myoma or trauma and infections. And in other causes, it comes to asymptomatic bacteriuria, recurrent UTI, genital tract infection, genetic predisposition, stress, environmental factors like lifestyle, suboptimal prenatal care, iatrogenic and idiopathic again. Malpresentations, as I said, transverse or a frank breach, or if there is a previous abortion history, it all contributes to preterm labor. Iatrogenic, if there is elective induction with the wrong estimation of gestational period, it will naturally lead to preterm labor. So risk factors are low BMI, short maternal height, history of spontaneous preterm birth. This is very important if there is a history of preterm labor in the woman. If she has already had a preterm labor in the early pregnancies, she is more likely to have a preterm labor in the current pregnancy. Bacterial vaginosis, asymptomatic bacteriuria, low socioeconomic status, short cervical length, which is again very important, substance abuse, and multifetal gestation. During the current pregnancy, if there is a multiple pregnancy, use of fertility medication like ART, hypertensive disorders of pregnancy, maternal diabetes mellitus, asthma, thyroid disease, if there is bleeding, history of bleeding in early pregnancy, premature rupture of membranes, and if there is a short cervix. Uterine malformations, placenta previa, abruptio placentae, polyhydramnios or oligohydramnios, anxiety and depression, use of tobacco and substance abuse. So when we come to clinical predictors, we have discussed all of this. This is just a slide for your knowledge. Multiple pregnancies, history of prior preterm birth and preterm labor. Biophysical indications, as you all know, if the Bishop score is more than 4 or equal to 4, and short cervix. Biochemical predictors are fetal fibronectin and cervicovaginal discharge. Others are interleukin 6 and 8 and tumor necrosis factor alpha and placenta alpha microglobulin A or phosphorylated insulin-like growth factor. So there's something called as an actin-Partus test. It's an immunoenzymatic test based on monoclonal antibody against phosphorylated insulin-like growth factor 1. A dacron swab is applied to the cervix, and then the swab is dipped in reaction buffer for 10 seconds and then discarded. The test strip is dipped in buffer, removed, and the result is red. If there is a single line, the result is negative, but if there is a double line, it's a positive result. This test has a very high sensitivity and specificity. It's called the actin-Partus test. So we come to signs and symptoms. Backache, contractions every 10 minutes, 1 in every 10 minutes or more often, or 4 in every 60 minutes. Cramping in the lower abdomen, menstrual-like cramps, feels like gas pain but not associated with diarrhea. Fluid leaking from the vagina, flu-like symptoms like nausea or vomiting, increased pelvis pressure, increased vaginal bleeding, increased uterine activity like hyperirritable uterus or vaginal spotting. How do you make a diagnosis? If there are regular uterine contractions with or without pain, at least 1 in every 10 minutes, if the cervical dilatation is more than equal to 2 centimeter and 80% effacement of the cervix, if the length of the cervix is less than equal to 2.5 centimeter, if there is funneling of internal os, increased pelvic pressure, backache, and if there is glary, vaginal discharge, or bleeding. Investigations, we do a complete blood count along with CRP. We do a routine urine analysis, culture and sensitivity, cervicovaginal swab, culture, and fibronectin, serum electrolytes and glucose levels, and an ultrasound. Next, we come to what's fibronectin. It's a protein that binds the fetal membranes to decidua, normally found in cervicovaginal discharge before 22 weeks and again after 37 weeks of pregnancy. So the presence of fibronectin in cervicovaginal discharge between 24 and 34 weeks predicts preterm labor. So management, either you prevent if it's possible, and there is appropriate management. If it's a preterm baby, then neonatal care is the only choice. First, you have to identify the high-risk women, then comes prevention, and then comes treatment. So clinical risk factors that include are, how do you assess the risk factors? Low socioeconomic status, poor antenatal care, malnutrition, extremes of maternal age, like if she has a pregnancy at a very later age, smoking, drug abuse, alcohol, heavy physical work, obstetric history, including a genetic predisposition, which is very important, uterine malformations, previous PTL, which is again very important, or PPROM, which is preterm pre-labor rupture of membranes, cervical surgeries, bleeding, history of bleeding in early pregnancy, short cervix and other pregnancy complications like preeclampsia and GDM, as we have already discussed. This is just repetition. So how do you prevent? Primary care is to reduce the incidence of preterm labor by reducing the high risk factors. Secondary care includes screening tests for early detection and prophylactic treatment. Example is tocolytics. We'll come to that later. Tertiary care is to reduce the perinatal morbidity and mortality after the diagnosis, like use of corticosteroids. So prevention is, first is identification and treatment of bacterial vaginosis. Treatment should be given to those in whom a diagnosis is made. Bacterial vaginosis, topical clindamycin has been the mainstay of treatment. Second comes progesterone. It's a weak tocolytic. However, there has been a renewed interest with some recent studies showing a reduction in preterm labor. Administration of progesterone in the second trimester to asymptomatic women with a short cervix less than 15 millimeter detected on transvaginal ultrasound or with a history of previous PTL significantly reduces PTL. It promotes pregnancy and uterine quiescence, like it quiets down the uterine contractions. 17 alpha hydroxyprogesterone caproate may be associated with a reduction in preterm labor. There is also reduced rate of birth weight less than 2.5 kg, intraventricular hemorrhage, and need for supplemental oxygen and necrotizing enterocolitis. Similar results have also been observed these days with micronized progesterone. Next comes cervical encirclage. There are four phases. There are four cases. First is if it's a history indicated, like if she's already had a preterm labor in the early pregnancies, the encirclage is normally inserted electively at 12 to 14 weeks. If it's ultrasound indicated, if there is a cervical shortening of 25 millimeter or less, then rescue encirclage. What's that? If there is bulging of membranes, a circlage is given after gently pushing up the bag of membranes. This has to be done very carefully, of course. Then there's a transvaginal techniques, that is McDonald's or Shirodkar in previous preterm labor or incompetent cervix. So under management, we come to the first is role of antibiotics. Pregnancy, preterm delivery is often associated with evidence of chorioamniotis, and the earlier the gestational age of delivery, the greater the risk. At present, antibiotics cannot be justified for the treatment of preterm labor in the absence of pre-labor rupture of membranes, according to ACOG. If rupture of membranes occur before the onset of labor, administration of erythromycin is associated with prolongation of pregnancy and improved neonatal outcome. Next is the role of steroids. There is good evidence that antenatal steroids should be given to mothers who have threatened preterm labor to reduce the incidence of neonatal respiratory distress syndrome, intraventricular hemorrhage, and perinatal death, and to gain time to refer the patient to a tertiary center. Corticosteroid dosage. There are two things, either betamethasone or dexamethasone. 2 doses of 12 milligram of betamethasone given IM 24 hours apart, or 4 doses of 6 milligram of dexamethasone given IM 12 hours apart. Magnesium sulfate is given it's given for neuroprotection. It should be offered to all women who are less than 36 weeks of gestation and established PTL or plan for delivery within 24 hours. The dose it's given 4 gram IV bolus of magnesium sulfate over 15 minutes, followed by an infusion of IV 1 gram per hour until the birth, or for 24 hours, whichever is sooner. It acts as a competitive antagonist of calcium for entry into monocytes. Next comes the role of tocolysis. Most believe that tocolysis is supposed to be beneficial in uncomplicated PTL. 5 classes of tocolytic agents have been described. Beta mimetics like ritodrin, isosuxaprin, terbinafine, salbutamol, calcium channel blockers like nifedipine, oxytocin receptor antagonists, NSAIDs like indomethacin, atosiban, which is an oxytocin analog, magnesium sulfate, nitric oxide donors, and progesterone again. But there are certain contraindications to tocolytics, like if there is severe hypertension, if there is cardiac disease, if there is uncontrolled diabetes, if there is chorioamnitis, placental abruption, or severe anemia or hypothyroidism. How do you arrest preterm labor? Bed rest is a very important left lateral position. The patient has to stay hydrated. Prophylactic antibiotics are given, and tocolytic agents like terbinafine, indomethacin, nifedipine, ritodrin, isosuxaprin, etc. Glucocorticoids is advocated in pregnancy in less than 34 weeks because it helps in fetal lung maturation and reduces the incidence of respiratory distress syndrome and intraventricular hemorrhage. The risks are there is PROM with evidence of infection. There are basically 2 principles in appropriate management: to prevent birth asphyxia and development of RDS, and to prevent birth trauma. So how do you manage the first stage? Patient is put to bed to prevent premature rupture of membranes and to ensure adequate fetal oxygenation. Strong sedative is avoided. Epidural anesthesia is of choice. Labor should be watched by intensive clinical monitoring. In case of delay, cesarean section should be performed. But the cesarean section has to be decided by the obstetrician when and why it should be performed. Only if normal vaginal delivery is contraindicated, like if there is a CPD or certain kinds of contraindications, then only go for a cesarean section. Otherwise, normal delivery should be preferred. Second stage, the birth should be gentle and slow to avoid rapid compression and decompression of head. Episiotomy may be done under local anesthesia to minimize head compression if there is perineal resistance. Tendency to delay is curtailed by low forceps. Routine forceps is not indicated. The cord is to be clamped immediately at birth to prevent hypovolemia and hypobilirubinemia. To shift the baby to intensive neonatal care unit under care of neonatologist. Immediate management is the cord is to be clamped quickly, but the cord length has to be kept long. In case exchange transfusion is required, air passage should be cleared of mucus, adequate oxygenation, Aqueous solution of vitamin K 1 milligram is given IM to prevent hemorrhagic manifestations. The baby should be wrapped, including head, in a sterile warm towel. Prognosis, it depends. If usually there is a very high perinatal mortality and morbidity in preterm labor, but with good neonatal ICUs, the survival rate of the baby weighing between 1000 to 1500 grams is more than 90%. And with use of surfactant, if you've already given steroids before that, the survival rate of babies born at 26 weeks is about 80%, but that again is very controversial because you need a very good ICU setup to survive that baby, to salvage that baby. Other measures to reduce preterm labor are smoking cessation, treatment of drug misuse, treatment of asymptomatic bacteriuria, maintenance of a normal BMI, avoiding an interpregnancy interval of less than 6 months and ideally less than 12 months, prevention and reduction of multifetal gestations like single embryo transfer and ART, low dose aspirin not recommended for preterm labor for moderate or high risk factors, but preeclampsia reduce risk for disorder and its sequel. No single biomarker performs well as a screening test treating preterm birth in asymptomatic low risk women. Thanking you. Stay safe.
Thank you very much, ma'am, for this nice presentation. Just give me 1 minute time, ma'am, to check the questions, if any. Ma'am, the first question is in case of tocolytic agent, first recommended drug is magnesium sulfate. But if any patient has some idiopathic reaction or hypersensitivity to magnesium sulfate, so what will be the other choice to treat this preterm labor?
In India, the most commonly used is isosuxeprin. Though we shouldn't, but nifedipine should actually be used. Nifedipine gives better results. It's safer and it can prevent, it helps us gain time to give steroid to the patients. And all good before the patient is referred to a tertiary center and good centers, nifedipine is the drug of choice.
Thank you, madam. And one question is, ma'am, vaginal progesterone reduced this risk of preterm labor. So before 30 weeks, you can say. So the concept is, at what is the exact time to give this vaginal progesterone to reduce the chances of this preterm birth?
These days, we usually give 17 alpha hydroxyprogesterone caprolate, 500 milligram IM once a week, or micronized progesterone 300 SR every day, once a day. Okay, and vaginal progesterones has actually no role basically in
Okay, ma'am. And is there any specific recommendation regarding the cervix length which can address these chances of preterm labor? Is there any recommendation or guidelines?
Ultrasound, if you see if there's a short cervix or if there's funneling of the internal os, then you can definitely know that there is chances of preterm labor. So a transvaginal ultrasound is very important because it helps to determine the length of the cervix.
And is there any specification of the length that below this length, there is a high chance of this preterm labor? Is there any recommendation or guidelines?
Less than equal to 2.5 centimeter. You should be guarded, the patient and the obstetrician should be guarded that she might go into preterm labor.
Thank you very much, ma'am. And one question is, in case of any infection like UTIs or in preeclampsia, So what will be your suggestions to take care, how to take care on that particular condition, so that that particular patient doesn't go with this preterm labor in the ending
Preeclampsia,
trimester?
preeclampsia, we generally prefer labetalol or calcigard. So to control the high BP so that she doesn't go into preterm labor. And infections can also be treated by antibiotics. As I said, bacterial vaginosis, clindamycin is the topical clindamycin is the treatment of choice. Apart from that, what other infections are you talking about? Preeclampsia actually has to be, you have to balance that between the mother and the fetus.
Thank you very much, ma'am.
Take care of both. And if the condition is very severe, you may have to terminate the pregnancy also.
Thank you very much, ma'am. So thank you very much, ma'am, for this nice presentation and to address a few queries also. So thank you very much for your valuable time on our platform to discuss on this very important topic, preterm labor. And thank you. And in future also, we will look forward for some valuable session with you, ma'am. Thank you very much, madam, for your valuable time. Have a good day, ma'am.
Thank you.